Hello, and thank you for joining me. My name is Helen Dawson, and I am going to be speaking with you about intimate partner violence. I would like to thank you in advance for your time and attention to this presentation. To begin our discussion on intimate partner violence, we must first establish what exactly that is. Intimate partner violence, or IPV, is a term that refers to any behavior within an intimate or romantic relationship that causes physical, sexual, or psychological harm to an individual within the relationship. Physical violence is deemed any act of physical aggression such as hitting, slapping, shoving, or throwing items by an individual to cause harm to another. Sexual violence is any non-consensual sexual activity, including both forced and coerced engagement by an included party. Psychological violence involves threatening and controlling behavior and includes verbal insults and humiliation and financial restrictions or manipulation. These acts of aggression may occur during or following a romantic relationship and expand to include stalking behaviors by a former partner. Though there are populations with increased vulnerability to IPV, individuals of any gender, sexual orientation, age, or socioeconomic standing may be victims of intimate partner violence. After understanding what IPV is, let's discuss the prevalence and epidemiology to appreciate the scope and importance of this public health concern. The exact numerical values varied across resources, but the most recent approximation provided by the Centers for Disease Control and Prevention, or the CDC, shows a staggering 41% of women and 26% of men who positively reported being victimized by intimate partner violence. While anyone may be victimized by IPV, women between the ages of 18 and 24, individuals with a disability, and LGBTQ+ identifying individuals reported significantly higher rates of intimate partner violence. While it is important to reiterate that anyone can be victimized by IPV, there are risk factors that increase an individual's vulnerability to IPV and likelihood of being victimized. Substance use, especially alcohol, has been correlated to IPV victimization as it inhibits awareness and judgment of environmental threats. Childhood trauma, particularly exposure to parental intimate partner violence, increase the risk of both victimization and perpetration of IPV. History of psychiatric treatment or a psychiatric diagnosis, as well as the presence of any disability, as mentioned on the previous slide, increases an individual's risk of IPV victimization. Poverty and financial distress also increase vulnerability to controlling relationship dynamics and consequently IPV victimization. Importantly, the cultural landscape and social environment an individual exists within can greatly increase the risk of IPV victimization. For example, existing in a culture or society that condones interpersonal or relationship violence both scaffolds potential for victimization and may lack structured consequences for perpetrators of the violence. The consequences of intimate partner violence are both individual and societal. The victimized person may suffer both or either physical and psychological harm. Physical consequences of violence include bruises, swelling, fractured bones, broken bones, traumatic brain injuries, and more. TBIs in particular have long-term broad consequences to the victim's wellness and functionality. Psychological impacts on the victim include depression, anxiety, post-traumatic stress disorder, substance use disorder, and more. While the consequences of IPV to the victim are significant and both short and long term, IPV extends to a public health concern that impacts communities at large. The CDC approximates 1 out of 5 homicide victims to be a direct result of intimate partner violence, a statistic that highlights IPV's role in generational trauma, overburdened legal systems, and its inherent proclivity to progressive escalation. We know what IPV is and how it impacts our society, so what do we do to prevent it? Looking at prevention through a tiered lens, tertiary prevention would include survivor support and long-term care management of the physical and psychological consequences. Secondary prevention would be the identification of IPV and intervention for the immediate safety of the victim. Primary prevention would be through public health initiatives and community education. For example, lobbying for legislation in localities with scant structured repercussions for intimate partner violence. When we think about secondary prevention of identification of and interventions to IPV, we need to understand how to assess and screen for intimate partner violence. Clinical settings provide opportunities for identification of IPV, and routine screening should occur at all new patient intake visits, annual checkups, and prenatal and postpartum appointments. Screening tools for IPV include the HITS, WAST, and PVS screening tools. HITS, or Hurt, Insult, Threaten, Scream, is self-explanatory with scores ranging from 4 to 20, and a score of 10 or more raising significant concern for the individual's safety. The Woman Abuse Screening Tool, or WAST, offers a more nuanced assessment of relationship dynamics with questions regarding psychological distress as well as physical violence. The WAST scores range from 0 to 16, with a score of 5 or more reflecting a high likelihood of IPV. The Partner Violence Screen, or PVS, is similar in content to the HIT screening tool and comprised of 3 questions. 1. Have you been hit, kicked, punched, or otherwise hurt by someone within the past year? If so, by whom? 2. Do you feel safe in your current relationship? 3. Is there a partner from a previous relationship who is making you feel unsafe now? If assessment and screening positively identifies intimate partner violence, prompt and tactful interventions are warranted. The immediate interventions for IPV are centered around patient safety. Safety planning would occur immediately following a positive screening, with consideration of removal from a current living situation, the protection of any involved minors or shared children, and notification of law enforcement. Crisis centers and emergency safety shelters are often necessary in the initial stages of intervention and can offer robust community supports for reestablishing the stability and functionality of the victim and any involved dependents. Long-term interventions are also necessary in the setting of IPV. Some physical harm, such as a TBI, may require extended medical monitoring and care management, and the psychological damage incurred by the victim and any involved dependents requires extended therapeutic mitigation by way of psychotherapy and often cognitive behavioral therapy. There are important legal considerations to be aware of in the assessment and intervention of intimate partner violence. While providers are advocates of patient autonomy, they are mandatory reporting laws that supersede the patient desires in the setting of safety concerns. Mandatory reporting laws vary by state and circumstance. Thus, it is important that providers have an awareness of the legal nuance of his or her locality. The majority of states within the United States require reporting of intimate partner violence in the following circumstances: a weapon was used, severe physical injury occurred, victim is diagnosed with a disability, or children are involved in the abuse or present at the home. There are professional and legal repercussions for providers who fail to report IPV that meets the aforementioned criteria, a reality that reinforces the importance of provider awareness of legal boundaries of his or her locality. Provider documentation is clinically important and in cases of IPV, equally legally critical. Accurate and objective documentation by a provider serves to support victims in establishing patterns of abuse and may be submitted as evidence in court proceedings. By using direct quotes and clinical metrics, the provider avoids documentation appearing to be subjective or the result of his or her own speculations. Legality is not the sole guide for provider interaction with intimate partner violence, as there are important ethical considerations for quality care provision. Patients have a right to autonomy, the right to make decisions about leaving a relationship and reporting the abuse. The only thing superseding that right is circumstances requiring mandatory reporting, like we discussed on a previous slide. The medical principles of beneficence, which is to act in the best interest of the patient, and non-maleficence, which is to do no harm to the patient, echo the balance of respecting patient autonomy while expressing and abiding by the boundaries of confidentiality and where those end, and mandatory reporting is required. Providers operating from a Christian worldview have an additional moral calling to advocate for the safety and protection of the vulnerable and to provide compassionate care to the suffering. As advanced practice nurses, we have an expansive responsibility in response to intimate partner violence. Critically, APNs are positioned to interact in clinical settings for screening and hopefully prompt identification of IPV. After identifying IPV, APNs work in interdisciplinary teams to simultaneously treat the harm done to the victim and establish safety. The role of the APN extends beyond direct patient care to encompass advocacy for the victim in legal proceedings. The education and training inherent to an APN equips them for involvement in public health promotion and expanded community responses to IPV. Community education programs and consulting for governing entities are examples of this.